most anything, not really, but I'll tell you whatever you want to know. Stupid things I did and things that weren't so stupid. Because, you know what I say, smart people learn from their mistakes. Really smart people learn from other people's mistakes. So I have no ego whatsoever about this. So back to class. Still not working, that is so strange. Let's go to where we were, strains and sprains. I'm not going to spend a whole lot of time on this. Use it as a resource. I do ask about it on most of my midterms, writtens, because it's extremely important that you know a few basic principles. And one of them is sprain is ligament, strain is musculotendinous. Number one. So sprains involve ligaments, strains involve the muscle and the tendon. You can have a sprain without a strain, and a strain without a sprain. So I don't want to hear when I see you in clinic, I don't want you to, I'm going to ask you your differential diagnosis after you've taken your history. I don't want you to say to me, okay, somatic dysfunction, cephalgia, herniated disc, facet syndrome, strain sprain. Did you not have me in 5th quarter and 7th quarter for semester? I don't say that. That would be harsh, but I want to. Because I'm not, oh man, we talked about this. Back in the day, the old ICD codes, I think 9s or 8s or 7s, we're up to like 11 now. They had their diagnosis codes. They had a strain sprain code, like cervical I think was 847.0 or something. So a lot of the old timers everything's a strain sprain. But let me reason with you, okay? Again, if you understand the why, it will be so much easier for you to remember. Wrists don't have a whole lot of muscle. Mostly ligament, right? They have tendons crossing, right? You can have a strain of a tendon crossing the wrist joint, but if they fall, they have a foosh, they're going to mostly sprain stuff. But the quads, it's so easy to strain a quad or a hamstring, which is purely muscular. What would you think would be easier? What would you think would be more likely to heal and heal quickly? A sprain or a strain, and why? More quickly. Which one would you think would heal more quickly and why?
Strain.
Haley?
Strain.
Strain? Who says strain? Who says sprain? Is that a half raise or is that a decoy maneuver? No, I'm kidding you. It is strain, and the reason is because muscles are full of blood. They're very vascular. I mean, they're red. They bleed. So they're getting lots of nutrition and oxygen and food. So if you strain your quad or your hammies and you're a football player, you can probably play the next weekend. But if you sprain your ACL, you might be out for the season. They heal very slowly. An ankle sprain is the most common sports injury. And they can heal slowly. An inversion sprain in particular. But that's another time for another class. But yeah, so ligaments are sprains. Musculotendinous T are strains. So if it helps you to remember tendon, strain, if you remember that, then the opposite is ligament for sprain. Ligaments heal more slowly. They just don't have as good of a blood supply. And the problem with ligament sprains is that if they don't heal well or it's a severe sprain, it can result in instability of a joint. You're not going to get instability of a joint from a simple strain. There are degrees of sprains and degrees of strains. I won't beat that horse to death. just trying, I had to put this in here because sports medicine to me is interesting, but this is, the MRI may be needed to quantify the degree of muscle injury. That is a really, really, really unusual situation. I'll be honest, I can't swear to it, but I don't think I ever ordered a single MRI for what I thought was a strain, ST. But if you really want to, maybe for a high-level athlete, you want to see how much tissue is torn. Because think about this also, gang. If you can think about what actually happens with a strain or a sprain, they're a subfailure tear. In other words, if this is a ligament where the fibers are nicely aligned and you tear a few of them, it's not full failure. It's not rent in two. It's still attached. It's just some of the fibers. It's like a rope. If you cut some of the fibers of the rope, it's going to be weakened, but it's still intact. You're usually not going to encounter a grade 3 sprain where there's a full tear of the ligament or muscle even. So it's a subfailure tear. That's all it is. Strain or sprain. I'll teach you a little bit about how do you decide. How do you decide when to x-ray somebody's ankle or foot? How do you decide when to x-ray somebody's neck? Well, first of all, let me disabuse you of the notion that you can open up a cookbook and practice cookbook medicine. That is not the kind of medicine I want you to practice. You are going to be physicians, so you have every right at the top of the food chain to say, you know what, I know that's the guideline, but I disagree, I'm doing it my way. You have every single right to do that. All you need to do is use your brain. So I'm going to teach you guidelines. I don't like rules, and I bring this up because sometimes they're called the Ottawa Ankle Rule. Canadians have done a beautiful job of objectifying and making what are called clinical prediction rules. Very good rules, but I would rather they be called guidelines. Because you are completely able to deviate from their rule. Just like physicians can prescribe off-label medicines based upon what? Their clinical judgment. So never apologize for that. Just understand you can do it. But I'm going to teach you this stuff because these are really good guidelines. So there's an app I want to tell you about. There are a number of them. I'll tell you the one I like. But I have nothing, it's free, but I'm sure there are some you could buy. I have no financial interest, full disclosure, none whatsoever. I couldn't care less which one you use. I'll tell you the one I've used for years. This is the description of the Ottawa Ankle and Foot Rules. All it basically says, these were designed for emergency departments. The Canadian C-spine rule, the Nexus rule, the Canadian head CT rule, the Ottawa knee rule, Ottawa ankle rule, Ottawa foot rule. Because what used to happen is everybody that sprained their ankle, doctors were scared, they'd x-ray them. And they found the yield was so incredibly low, they said there's got to be a better way, but we don't want to get our rear ends handed to us in court. So some very, very smart people said, let's study this. And they did. And they came up with some rules based on data that is not infallible, but the missed fractures, when you use these rules, the percentage of missed fractures is so tiny as to be clinically insignificant. Now, if you're the patient, you're the 1 out of 1,000, well, then you are. But it gives some cover to emergency department doctors, and that has now been translated over into clinical practice. It gives you a little bit of guidance. And the nice thing about it, here is it's called MedCalc. And it's free. And one of the things I like about it, this is right off my phone. And one of the things I like about it is you can save your favorites. And when I was teaching at my other institution, I went through this with them. So I showed them the ones they're most likely to need. And then this is what it looks like. It'll tell you what to look for, and then it asks you questions, and you hit the little button. And inability to bear weight immediately after injury and in the emergency department or in your office. If it's a no, x-rays are needed. If it's a yes, you go to the next one. Tenderness in the posterolateral 6 centimeters of the medial or lateral malleolus. Yes, x-rays are indicated. No, x-rays are not indicated. Patient can take 4 steps with or without support. No, x-rays are indicated. In the emergency department. No, x-rays are indicated. Yes, x-rays not indicated. So that's really a nice little thing to have. But the neat thing about it is you use them like 3 times and it's part of you. It's really simple. It's designed that way. Skip through this because it's really more information than we need in semester 5, but sometimes I get carried away. Joint instability is the most ominous sequela of joint sprains, ligament sprains, because first of all, if a ligament is sprained repeatedly, then you can end up with accelerated degenerative changes at that joint. Each time you have a sprain, it doesn't heal quite as well as the normal, and each successive sprain. So let me ask you this. Other than just the activity you're doing, let's say you do Zumba, and you're always doing this number. Well, you have a statistically greater chance of having an inversion or eversion sprain than somebody that just goes forward and back, right? So let's say you're a Zumba teacher, and you wear bad shoes, and you've turned your ankle so many times. Why does it seem to happen over and over again? Well, number one, the ligament is never just like new, especially if you didn't rehab it. Number two, you lose some proprioceptive input from the mechanoreceptors down there every time you tear that ligament. A little less communication goes from your ankle to your brain, telling where your ankle is in space. So every time that happens, you have a little more likelihood of doing it again, and that is virtually axiomatic with people that don't rehab their ankles. They have more than one sprain. So what can you do about it? Well, you can price them, right? Protection, price rule. You've heard of the price rule, right? You've not heard of the price rule?
No. Rice.
Well, rice, okay, well, the P, I'm sorry, I thought you'd heard about that. The P is protection. Well, I thought I had that here. I have it somewhere else. So protection, rest, ice, compression, elevation. And I use stirrups, air cast stirrups for the ankles because you can wear them in shoes. And they allow forward and backward movement, but they inhibit medial and inversion and eversion. So movement is life. In the old days, you'd brace somebody, cast them, put them in ace bandage, and give them crutches and tell them not to walk. I've done that in years past. But the data say now, if they can walk, let them walk. Mobilize them. Early mobilization, reasonable mobilization, they're going to heal better. So if you can get them in an air cast and just tell them, you're going to have to take some time off Zumba, my friend. You teach it, well, you're not going to teach it for 2 weeks. Sometimes you just got to lay it out there. They'll do what they want to do, but believe me, the first time, you'll always know when they didn't listen to you. Because they'll come in on Monday and say, I should have listened to you. I did it again. And no worries, no judgment from me. Never. But it'll happen. Not everybody's 100% compliant. But if they understand why you're telling them, they're more likely to comply. So you put them in a stirrup, and those are cheap. You buy one size fits all for probably $15 on Amazon, and they fit right in their shoe. Simple to use, ridiculously simple to use. I like air casts, but That's just because I like Aircast. I have no financial interest whatsoever in Aircast, but there are many, many different types. You just keep them from everting and inverting, but let them move this way, and they can heal better. So you want to rehab them, you can do wobble board, what we used to call BAPS board, biomechanical ankle proprioceptive system. It's just a wobble board. Even starting them seated, and they put their involved foot on it and do figure eights, or just forward and backward. Just start that gentle mobilization as soon as you can, out of the acute phase, and get them to start to reestablish those pathways. And when they're done healing, they will heal much better. And you'll have given them frankly, it pays handsomely if that's your thing. I bought a couple wobble boards because I thought they were interesting, but I thought there is no way I'm going to sit here and watch a patient wobble their foot. So I would send them to PT if they had a really bad sprain, especially recurrent sprains. PTs they've got all that stuff all over the place. Because I didn't dabble. So anyway, my PT colleagues were just fabulous. We had a very symbiotic relationship. I treated a lot of them, and I wouldn't have hesitated to go to them if I needed shoulder rehab or something. Thankfully, I didn't. Ever heard of reflex sympathetic dystrophy? CRPS, complex regional pain syndrome. Okay, we'll spend more time on that in another semester, and some I think in this semester. But for now, it's a very, very life-changing, potentially life-changing, sympathetic. It's an autonomic problem. It doesn't make a lot of sense, but it can be life-changing to people in a bad way. Compartment syndrome with a really bad strain. Because what happens is when you have a membrane-limited structure like a muscle, it's kind of like a sausage. And if you take a sausage and overfill it, something's got to give. So goes the weasel, right? Well, muscles are in various areas have anterior, lateral, posterior compartments, and if blood gets into those compartments and products of edema otherwise get into those compartments from something called diapedesis, they overcome the ability of that compartment to what'll happen is it'll get compressed so tightly that the neurovascular structures will end up becoming compressed. And you can end up with acute compartment syndrome, acute compartment syndrome, there are two major types. There's chronic exertional compartment syndrome, where you go to the gym and work out too hard, your arms you can barely move the next day. It's probably happened to all of you. That goes away as soon as you quit working out. And then you can go back in and just be a little wiser, a little wiser. But acute compartment syndrome is a surgical emergency, and there is no known conservative treatment for acute compartment syndrome, and it affects limb and possibly life. So we'll have to get into that part in more detail later, but just remember, if you strain a muscle and it starts to bleed, you develop a hematoma. Usually that'll be fine, but if it is really, really bad, depending on the area, especially a crushing injury, you can have massive internal bleeding of the compartment, and it just overcomes the ability of the neurovascular structures to adapt. So blood gets cut off and nerves die. And you can even end up with something called Volkmann's ischemia, where the hand is like this and all atrophied and it looks horrible. We talk about that either in emergency care or in this class. You will learn about it though, don't worry. There's something called myositis ossificans. It is generally a nothing burger. All it is the calcification of a hematoma. but it can start developing just weeks after an acute injury. And here's an example. A contusion is just another word for a bruise. So here's a 19-year-old that got hit back here. It's a football injury, and a month later, he's already got this what they call fluffy calcification. That's suggestive of early myositis ossificans, myo, muscle, itis, inflammation, ossify, bone, cans. So it's essentially ossification of the hematoma. It's a month later in a 19-year-old. Very, 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 very rarely these can have what's called malignant transformation. That's a zebra that you don't need to learn about, but if you look it up and see that, yes, I mentioned it, but I've never seen it. I've heard, it's like little green men. I've heard they're out there. I've just never seen one. I've told you there are grades of strains and grades of sprains. I'm not going to read this to you. You should have already heard some of this anyway, but basically the grade 1 is better than a grade 2, and a grade 2 is better than a grade 3. The disability after a grade 1 is minimal to none. A grade 3 can be a complete rupture. Seems to happen more often at the musculotendinous junction. There's a theory about that. That's some resources say that's a zone of relative hypovascularity, where it's like for some reason at that juncture of the tendon and the muscle, there's not as much blood supply, so it makes it susceptible to tearing. And you'll find that rotator cuff strains or tears, which almost always involve the supraspinatus, tend to occur about 1 centimeter proximal to the tendon. Zone of relative hypovascularity. Here we go. There's your Price rule. I thought I had that in there. You can read that again. We've already talked about it. Mobilization, mobilization, mobilization. That is current literature. 5 years ago, might have been different. You're getting current stuff. You've heard of Wolff's Law, which is the bone remodeling law, that bone will remodel in accordance with the stresses that is placed upon it. If you walk on hard surfaces, your thigh bones will get thicker. You should have, if you haven't already heard of Davis's Law, which is the corollary for soft tissue healing. It is soft tissue heals in accordance with the stresses placed upon it. So if you have a ligament that's torn and healing, it might heal in a haphazard, disorganized way if you just let it heal. And it will heal. It's not a question of is it going to heal. I used to tell my patients this all the time. If you break your arm and don't get it in a cast, it's going to heal. The question is how. Is it going to heal crooked? It'll heal and it might not even hurt, but it'll be crooked and it won't work right. Or it might be a non-union. Ligaments, muscles, tendons, the same thing, but ligaments primarily, it's going to heal, but it might heal like this instead of like this. So if we stress it along the lines of those fibers, those ligament fibers, collagen fibers, they will heal in a better organized pattern. This has been shown in study after study after study. I think the earliest one I ever saw was in 1988. It was an orthopedic journal in Australia where they did rabbit knees in fairly barbaric fashion, but it was the right thing to do because they found out that ligaments in rabbits were healing up to a year after the injury. So healing in ligaments takes a long time. So if you get some rehab in, they have a better chance of it healing better. Muscles, like they do in Brazil, that means who cares? Rio. I learned that in Rio. But I always thought that was so funny. And when your lights are on when you're driving, they do this. I have no idea why. The daytime running lights, come on. But anyway, the alignment of fibers is really helpful to work on if you can get it to heal better. The quality of healing makes a huge difference. I broke my arm. I'm the only person on earth I know that broke my arm playing baseball. And I remember how much I hated when I was 12 years old wearing a plaster cast in August. And yes, I was tempted to cut it off. And I've heard of people that have done that. But I got a Colles fracture, run into first base, and I had a collision with the first baseman. And not on purpose. I wasn't mean. He just got in my way, and it was one of those things. And I couldn't stop. I went up in the air and I came down. I had a big old foosh, and it hurt so badly that I almost passed out. I remember seeing dots. But I got up and ran to second. They stopped the game. Dr. Coach comes out and looks at my arm. It's just a little strain. You're good to go. Okay. So I played the rest of the game with a Colles fracture. I batted with a Colles fracture. Next day I woke up, my arm was as big as a balloon, and my mom took me in. And thankfully it wasn't displaced, but that could have ended poorly. Because sometimes they displace so badly that they have to be, you have to have an O-rift done. And I didn't, thankfully. But I still remember going up the elevator to the orthopedic place thinking, what's going to happen to me now, you know? Anyway, all's well that ends well. So you have to rehab them, and again, stuff heals better when you put a little stress on it. Controlled stress, mobilization. It heals better. You can do this, and you can get paid for it. Same thing with sprains. Same type of stuff. With kids, there's something called Salter-Harris fractures. We'll talk more about that next time. But sprains are uncommon, much more uncommon in kids, and the reason is because they have bones that have not fused. They have what are called growth plates. And there are epiphyses and apophyses. An epiphysis is a growth plate in the spine or in the knee, for example, in other places. An apophysis is an outgrowth, a bony outgrowth. For example, the tibial tubercle, there's something called tibial apophysitis, which is AKA Osgood-Schlatters disease. It's just where an immature apophysis hasn't fused yet and the kid's been kicking too much. And it just puts a lot of stress on the apophysis. You remove the offending activity and they'll heal. 40 years ago, they put a kid in a cast for 6 weeks. Detrimental, unnecessary, overreacting, but it was the best thing you had to do. Tibial apophysitis, Osgood-Schlatters disease. So growth plate fractures, because those growth plates are weaker than the ligaments, the growth plate will break. It's also called a physis. It's where all the length of the bone happens. That's why growth plate injuries can really cause problems later if they're missed, certain types especially. Like a grade 6, the crush one, kind of rare, but boy, when it happens, it can damage the growth plate permanently, and what'll happen is one side will grow longer than the other. So you really have to be careful with what are called Salter-Harris fractures. Salter-Harris fractures, that's the classification system for growth plate fractures. They're considered fractures, and they're to be treated as fractures unless otherwise proven. Salter-Harris. And again, the apophysis is going to be more likely to tear than the ligament because it's at a growth center. And that is that. We made it through. Let me just, since I have a couple of minutes, and I'll let you out early, but let me just kind of switch really quick to a different let me see, I'm trying to get to my
It's praying hard.
I just want you to get a look at this. Okay. So here, this is the orthopedic neurology. Let me open it here, get it bigger. Okay. So this is the textbook. This is the latest version. This goes through all kinds of cool stuff. It gives you, I've got the article about conflicting dermatome maps. This is the grading system. This is the same thing, two different sources. One of them came out of Cipriano, one of them came out of Hoppenfeld. Both of them are orthopedic, are both board references. We use this standard. There's a Mayo Clinic standard and all that other stuff. Some is 0 to 10, we're 5 plus, 5 minus, 5 plus plus, 5 minus minus. I mean, it's just oppressive. This is the scale we're going to use. This is the scale you will encounter in boards. This is the myotatic reflex scale. 9s is the National Institute for Neurologic Diseases and Strokes, and that's the standard we use. And this is, I'm giving you, you don't know how proud I am of putting together 2 or 3 tables. I just want to sit and just enjoy that for a second. Probably took me like 2 hours to do, I know. But I was so, colors and everything. But anyway, absent is called areflexia. Like amenorrhea, whatever. Trace hyporeflexia may require what's called reinforcement. The most common reinforcement technique is called the Gendrasik maneuver, which I have. Normal. 3 is brisk or exaggerated. 4 plus is with clonus, and it's hyperreflexia. Clonus is suggestive but not pathognomonic for upper motor neuron lesions. You aware of that? You've heard this, I'm sure? Okay, good. You've heard of the Babinski sign and all of this, right? Good. Here are just some simple principles that I've got for you. And again, I'm not going to this is not neurology, but you need to know this. And it's good refresher. And it just cuts right to the chase without a lot of theory. I wanted to show you some of I've even got, I think this comes from the Stanford 25 series. It's a really nice summary of obtaining reflexes. This shows you a real clonus and a real Hoffman sign. Those are pathological reflexes for upper motor neuron. Now look at how Hoppenfeld does this. Does anybody have Hoppenfeld? Are you familiar at all with Hoppenfeld?
No.
No? Well, you're going to be. I completely respect what you've been taught already, but this is my class and this is what I'm teaching, okay? So get used to Hoppenfeld. This is what's on when I went to part 4, I was given a book that had what was on the exam and what the acceptable variants were, what the standards were, and it was a rubric, and it was always Hoppenfeld. So look at how nicely summarized he does this. Just nice. Notice no pinwheel. Although he does use a pinwheel in some cases. But on a few of these, he got C6 and C8 messed up, and I got that. I sent him in stuff. But look at this. Look at how it's for visual learners. Isn't that helpful?
Oh, it's awesome.
Now he's already getting you ready for C6. You see C6? He's got his hand like a 6. It's just brilliant in my view. He goes through how to check the reflex, and he uses that wretched Taylor hammer, and that's fine. Bicep reflex, 5 fingers, C5. You might have heard, I'm not sure, it was surprising to me that in my other institution there was some question about it, whether there was a C6 reflex or not, but it's the brachioradialis reflex. C5 is bicep. These are also, by the way, don't get confused because there's overlap. Some of them would be called a C5-6 reflex or C6-7 reflex. Yes, there's overlap. We have redundancy built into us, but it's the primary innervation that we're looking at. If you have a great big, the medical term is called honkin herniated disc, hitting your C5 nerve root, you're more likely to see a bicep reflex drop than a tricep reflex drop. These are the neurologic packets I was telling you about, how he breaks it down and shows the different levels, and he stipples the one that's being looked at here. This tells you what disc is involved. Very important that you know this for your boards. What is a C5-6 herniated disc? What nerve does it compress?
C5.
Are you sure?
Yep.
Are you really sure?
Yep.
You're already getting fired up. That's good. Yeah. I know it seems kind of almost childish for me to keep doing this, but I do it for a reason. You understand, right?
Mm-hmm.
So, and it just goes on, and oh, that's hard to forget, right? C6 is brachioradialis. This is another different look, and I highlight stuff for you that's really important. So anyway, that's Hoppenfeld, and it goes all the way through. It goes all the way, and then he goes to lower extremity. Look at how nice that is. He talks about demarcation, which is the tibial crest. Everything to the one side of it is S1 or L5. Everything to the other side of it is L4. And then the back of the leg down to the outside of the foot and the plantar surface of the foot is S1. It's just really nicely set up. Easy to remember. If I can remember it, you can remember it. That's why I got the color version for you. Yeah, there's a couple down toward the bottom, I think, that I'm going to just go ahead. If you end up buying this, he messed that one up. You know, it's not, these are not, low, L5 is not upper extremity, so I don't know how the editor missed that. But I wanted to show you this because it's a beautiful summary of motor, sensory, reflex. You cut that out and take it with you to your study session with your pals, and it's just a nice summary.
Is this his whole book, or that's just part of it?
No, it's not. But I took, you know, again, you guys, could you possibly read all these books?
Mm-hmm.
So I did it for you.
Thank you.
And I made these cute little PowerPoints, trying to make it to where you can. It does you no good to say, you know, read 400 pages and I'll test you on it in 3 weeks. So I try to anticipate what would I want to know, and that's how I do it. But I really like my Hoppenfeld. So anyway, I think that's enough for now. You guys have really been pretty fabulous about all of this, and I can't tell if I've canceled my Zoom or not. I've got so many things going on here. But at any rate, this is why I use the texts I use, because they are going to be what you're going to be tested on. So, why did this? So you guys are done, and all I can tell you is thanks for your attention. I know it's a lot of stuff.
Thank you. You might want to click in the video, I think, if you're trying to go back to your Zoom.
Click into that.
Over the right, to the right. No, in the